So we're going to have to move forward here to discuss frontline therapy, and at this particular ASH, there were a lot of presentations, oral and poster, about frontline therapy, all different types. The key question has really been, what is the story by turning the triplet into a quadruplet with the addition of daratumumab, the monoclonal antibody? And so I'm just going to show a little bit of data. So obviously the starting point, the sort of standard of care, is VRD with an autologous stem cell transplant for those patients based on the IFM study with excellent PFS. With this, we're still waiting to see the impact on survival, and we can maybe talk about that separately. But we also have a very nice study from the Spanish group where the number of cycles of the VRD was extended to 6 using a change in the dose and schedule that allowed that to happen. And so we're certainly focused on the number of cycles of therapy as something to be important and to consider if it can actually be given to the patient. But we're all very excited about all the different quadruplets, and this just shows one set of curves from the daratumumab VTD study versus VTD, the Cassiopeia. And this is interesting because Philippe Moreau presented it looking at MRD, in this case combined with PET-CT. And the interesting thing is that combined negativity of MRD and PET-CT gives you better outcomes in addition to obviously the added benefit of the daratumumab. And so then we have the update of the Griffin trial, which adds daratumumab to the VRD. And again, very promising results, very early, but obviously with really excellent early response and survival data with Dara VRD. And I think that everyone is optimistic that this will be a very powerful regimen. In addition to that, we have very striking data presented by Luciana Costa looking at an adapted approach but using daratumumab carfilzomib Lamdex, Dara-KRD. And you can see here, if you look at the far right curves, a very high percentage of deep responses, both using conventional IMWG criteria, but also different levels of MRD with NGS, 10 to the minus 4, 10 to the minus 5, 10 to the minus 6. So very, very impressive depth of response results. And of course, we have the update from your study looking at the addition of daratumumab to VMP. And so we have this situation of several combinations with Dara. And so the question is, with these great results, are we going to just switch over and will some of those become our new standard of care? Or are we still a bit cautious and will we start with triplets? So Joe, do you want to start with this one?
Sure, yeah. No controversy here.
An easy one?
Yeah, this just lobbed me an easy one. Well, actually, to be honest, I really do think if we start with the transplant-eligible population,
right,
I really think we are going to move towards those quadruplets. The issue there, I almost feel like when we had this conversation at this table a number of years ago, are we going to stick with doublets or go to triplets?
Yes.
There's always the law of diminishing returns. I mean, the data for just VRD is still quite impressive. But there is always a challenging situation where some patients don't do well early on. And I think the idea of adding daratumumab to either VRD or KRD primarily, although depending on what's available in different countries, sometimes it's VTD or potentially IRD, I think that's going to happen. I think the Griffin study is likely going to lead to us using a lot of Dara VRD, in particular here in the US, or potentially Dara KRD as we're often using KRD in the high-risk situation. And I think that will be more the standard of care in the not-so-distant future. Partly because adding daratumumab to those two regimens adds benefit without a lot more side effects or toxicity. I think in the transplant ineligible population, it's going to take us a little bit longer to come to that conclusion. I mean, apart from your study with Dara VMP, we really don't have any other quadruplets in the transplant ineligible population. And we're seeing a lot of Dara RD and VRD in that situation. And we've tended to favor VRD, as you mentioned here, modified or a little bit lighter.
right.
You know, there's about 10 different ways to give VRD, but,
Right.
dose reducing a little bit towards a patient's frailty and comorbidities, and particularly in the high-risk patients. And then in the standard risk patients, having a choice of either VRD or DARA-RD,
Right.
I think for at least now remain the
Right.
standard.
So how do you view this?
Yeah, so I basically agree with Joy, and I think that in the transplant-eligible population, definitely the 3 drug-based combination plus the monoclonal antibody is going to be the standard of care. In fact, when we see this list, it's true that it is possible to add data to VTD, a much more cheap regime, but also we can add it to KRD, a much more expensive combination.
Right.
But the good news is that we have excellent data coming from the different combinations. So physicians can be confident choosing either VRD, KRD, VTD,
Right. The results
plus the
very good across the
monoclonal
board,
antibody.
yes.
Absolutely. And in the non-transplant eligible population, it depends because we can call honestly 4 drug-based combination to VMP plus DARA, but honestly I understand that it's not the same that VRD plus DARA. And this is not a real 4 drug-based combination.
Right.
DVMP has shown benefit in overall survival, and again I think that this is a combination that can be affordable because it
Right.
is not going to be very expensive, and it's definitely useful for the elderly patients. However, it's true that if we go to the MAYA study, the median progression-free survival expected for DARA
Yes.
Lendex, and this is just a 3 drug-based combination, is going to be excellent.
Yeah, absolutely.
And the same for VRD, with the possibility of using even VRD light. So definitely I think that even in the elderly population, DARA will be added for sure, and depending on affordability, availability, and so on, it is possible to use VMP if the economical situation is
Right.
not very good, Lendex or even VRD in the future.
Absolutely, yeah. So that it's great that we have these possibilities depending on drug availabilities and the status of the patient, comorbidities, and frailty factors.
But the good news is to have clinical data coming from all combinations.
Yes, yes, exactly. Yes,
And that
yes.
each of the combinations can be modified to that patient's needs.
Yeah.
And I think
Yes.
that's what's important. With
Right.
this idea that there's only one cookbook way of doing VRD or doing KRD or now DVRD, I think this is going to be very helpful that we can make modifications now with
Yeah.
so much more experience where we don't want to overdose nor underdose patients with the principle of leveraging the combination up front and then potentially stepping down a little bit with time once the disease is under better control so that we don't provide too much toxicity. Like when we do VRD, we don't continue the V indefinitely,
Yeah,
but we can
absolutely.
you know, step it down. I typically will step it down to every other week for a
Yeah.
while before discontinuing it.
Yeah.
So maybe a quick question before we move on. Is there a possibility that with these much better combinations, we are looking at maybe autologous stem cell transplant might not be always automatic in the future?
Well, personally, maybe. I think that we need much more data. Definitely the Forte study conducted by the Italian myeloma group is giving us important data.
Right.
And personally, I consider that minimal residual disease as well as a risk status can potentially drive to not, well, drive the situation in order to avoid the transplant in some
Yes,
patients.
yes.
According to the results of Francesca Gai, maybe patients at standard risk and achieving minimal residual disease negative after a 3 drug-based combination plus the monoclonal antibody maybe do not need the transplant in the first line.
Right.
However, high risk for patients with ISS 2-3,
Right.
maybe these patients, at least with the data we have today, transplant should be considered
be
the standard of care.
Right, right. Okay, we have to move on, but that was also a topic that came up in several discussions. Where are we with the role of transplant?
And I think that'll be a feature of this conference series
Maybe next
for
year.
several years to come.
Every year.
Absolutely, absolutely.